this refresher course on imaging of hereditary tumor syndromes. There are going to be 4 speakers in this refresher course covering different tumor syndromes, and we'll stop after each one and get questions and summarize at the end. Okay, so my name is Pete Choike. I am going to lead off with imaging of hereditary renal cancers. And as background, renal carcinoma is a very common diagnosis worldwide. Over 271,000 worldwide diagnoses, 116,000 global deaths. In the United States, there are at least 200,000 kidney cancer survivors. So it's a major worldwide disease. And genetic information is becoming increasingly available, but the question is how to use it. And at the NCI, where I work, we've been studying hereditary renal tumors in the hopes that they'll provide a link between imaging and genetics for the future. So the idea is that instead of the conventional history that we receive, my favorite being F/U, we're going to also have genetic history in the form of actual genes that will lead to the informed eye, that in turn will alter the prior probabilities when we do reports and lead ultimately to more accurate diagnoses. So I'm going to discuss 5 related hereditary forms of renal cancer: von Hippel-Lindau, hereditary papillary renal cancer, Birt-Hogg-Dubé, hereditary leiomyomatosis renal cell carcinoma, and succinate dehydrogenase syndrome. And the information that I'm going to give to you is based on extensive screenings of families with renal cell carcinoma. And you can see the numbers of affected, screened individuals, affected individuals, and numbers of families with these respective diseases. So they're quite an intensive effort to identify these patients and then identify the genetics associated with the disease. So I'll just start with von Hippel-Lindau disease, which, as you know, affects not only the kidneys but the adrenals with pheochromocytomas, pancreas with cysts and neuroendocrine tumors, hemangioblastomas in the brain and spine, angiomas in the eye, and endolymphatic sac tumors in the inner ears. So it's a systemic disease. I'm not going to illustrate all the radiologic features. I'm going to focus on kidneys. And what we find in the kidneys is that there are numerous microscopic and macroscopic tumors. Estimated on average 600 clear cell carcinomas per kidney per side, up to 1,300 cysts per kidney. These are microscopic lesions. So the kidneys are really quite devastated. It's an autosomal dominant disease. All the lesions are clear cell carcinomas of the kidney. So it's clearly whatever causes von Hippel-Lindau disease has something to do with clear cell carcinoma of the kidney. So I think you're familiar with the appearance of von Hippel-Lindau disease. It has both cystic and solid components. It's characterized by these cystic solid lesions that you can see here bilaterally. And here's a 40-year-old male, obviously not screened very well, but he's eventually discovered his renal function is good, but he has operable lesions. During these operations, and this will also apply to every other syndrome that I talk about, we use intraoperative ultrasound to not only diagnose what we've seen on CT, but also intraoperatively identify lesions. So on average, we remove 12.8 lesions per kidney. It's a tremendous way to find additional lesions. And the whole idea behind doing this is not so much to eradicate every lesion that the kidney has, but rather to reset the clock so that the next surgery is as far removed from this surgery as possible. So this same individual, post-operatively, all these solid lesions have been removed. Some of the cystic lesions are retained because they don't have the same kind of malignant potential. His renal function is preserved, and he can go on for a number of years before requiring additional surgery. Also, a statement that will apply to all of the lesions that I discuss is the great advance of robotic-assisted partial nephrectomy, which enables much more accurate and minimally invasive resection of tumors than was possible with open resection. So even tumors that are fairly large, extending to the collecting system, can now be done with robotic partial nephrectomy, and you can see the post-op findings 3 months later. So what is the gene causing von Hippel-Lindau disease? It's actually a very short gene on the 3rd chromosome. These are just sites that have been identified as mutations, and virtually I will say 100% of the people with von Hippel-Lindau disease have a problem with their gene that can be identified and therefore traced through that family. And the gene mutations come in all kinds of varieties. So the most common is some kind of abnormality, so-called intragenic abnormality in one of these exons, one of the 3 exons, either a missense, frameshift, nonsense. There can be complete deletion of this gene, which is actually, interestingly, a mild form of the disease, or a partial deletion of the gene, which is a very serious form of the disease. And splicing defects, so these little areas between the exons, they can have abnormalities. That has significance in terms of VHL. And when you look now at sporadic renal cancers, you can see that the same kinds of mutations that we see in VHL show up in sporadics. So this is a very significant gene. And recently, Gerlinger described a primary cancer with metastases and looked at the genetics of the primary and the metastases. And this is the so-called branching phylogenetic relationship. And you can see that the von Hippel-Lindau gene is sort of the trunk gene of this tree. All the lesions, whether primary or metastatic, harbored a VHL mutation. Then the metastases began to develop other mutations that are denoted here. So VHL is a fundamental originating gene for clear cell carcinoma. Now, I won't belabor this point, but we do have an understanding of what the VHL gene does, why it acts the way it does, and why it creates cancer. We're not quite so sure about why it creates kidney cancer as opposed to other kinds of cancer, but we do understand in the normal state, von Hippel-Lindau protein is involved with the degradation of a very fundamental protein called HIF-alpha, HIF-1 alpha, which is hypoxia-inducible factor alpha. This is one of our basic response elements to oxygen sensing. So in the presence of hypoxia, this is expressed and leads to all kinds of downstream effects that we'll talk about in a second. But normally, in a normoxic environment, that HIF is simply degraded by VHL. In a mutation, or in hypoxia, the VHL no longer is able to degrade the HIF-1 alpha, and it accumulates multiple copies, leading to increased VEGF, GLUT1, PDGF, a lot of growth factors that ultimately push cells towards the cancer phenotype. And this has implications for the therapy that's already being tested and used in patients, more metastatic patients with renal cell carcinoma, clear cell carcinoma. So we can attack VEGF, that's downstream of HIF, PDGFR, EGFR, and there are a number of drugs listed here that are applicable to that. So the next kind of cancer that I want to talk about is papillary type 1 cancer, which, as you may know, has a very poorly perfused type phenotype on CT. So they're clearly tumors, but they're not very enhancing, unlike VHL. Also, they're not cystic. And when you look at them, they have a papillary phenotype. They tend to have these small nodules. So we understand the gene behind hereditary papillary type 1 disease, and it's the MET gene, which is MET receptor, and that has a receptor tyrosine kinase that results in proliferation of cells, increases morphology changes, as well as motility changes. And what happens in the hereditary form of papillary disease is that this tyrosine kinase domain is in a permanent activated state. It doesn't require any ligand to bind to it for it to activate. Instead, it's constantly on, and it's leading to proliferation of cells, eventually leading to papillary renal cancer. So we have some idea about that. That also gives strength to the idea that perhaps we could treat metastatic forms of this disease with a tyrosine kinase inhibitor. Multiple available now. Ferretinib has been tried in clinical trials and has been successful in at least stopping progression of disease. The next disease, hereditary form of renal cancer, is chromophobe carcinoma. As you can see here, it's a homogeneously enhancing lesion, not the kind of necrosis that you see with clear cell carcinoma, but it's much more enhancing than papillary renal cancer. And there are hereditary phenotypes of this. So when you look at patients who come from families where chromophobe carcinoma is very common, you begin to notice that they have bumps on their faces, like these little fibrofolliculomas. Here's a biopsy of one of them. And this is really part of a dermatology syndrome called Birt-Hogg-Dubé. So Birt-Hogg-Dubé has lung cysts that I'll show you in a second. It has some slight increase in colon cancer, but it has a profound increase in the number of renal cancers, particularly chromophobe carcinomas, but as I'll show you in a second, others as well. And here you can see a bunch of chromophobe carcinomas. Here's a very large one in a patient with Birt-Hogg-Dubé. So there's actually a spectrum of renal tumors. Unlike the first two syndromes that I described, this one has a spectral distribution that includes chromophobe carcinoma, includes clear cell carcinoma, also includes classic benign oncocytoma, and hybrids between clear cell and chromophobe and onco. Leading credence to the idea that oncocytomas can be a precursor lesion to chromophobe and are somehow related to clear cell. So this is a very complex syndrome. It hasn't fully been worked out what specific genetic deletion leads to specific phenotype at the histology level. And it's something we're currently working on. So this is a patient who's pre-robotic left partial nephrectomy, high-grade clear cell renal carcinoma, despite the fact that it looks very much like all the other chromophobes that I just showed you. And here's a hybrid renal cell carcinoma also looking pretty much like the chromophobe, indistinguishable by radiology alone. But if you knew that this patient had Birt-Hogg-Dubé, you would be thinking about these various tumors that they might have. So the gene involved with this is called folliculin, FLCN, and numerous mutations have been seen across that. Notice in VHL there were 3 exons. This is a 14 exon gene. It's got multiple deletions, substitutions, insertions, very complex. No wonder that it results in a very complex array of renal cancers. And here are the example of the lung cysts that we see with BHD. So as we were studying families, we noted that most of the hereditary renal cancers were discovered by screening and early and very successfully treated. So most people survived very well. But there were a number of families with devastating cancers where people were dying very young and seemed to have very aggressive phenotypes. And we began to investigate that. At first, we saw lesions like this and placed them sort of in the papillary category from just their poor enhancement. So it's a 2.5 centimeter lesion, actually described as a cystic lesion, although I don't agree with that. At the same time, this patient already has a 2 centimeter hilar node, and this is a young patient. I began to link it to hereditary leiomyomatosis renal cell carcinoma, or HLRCC, which includes cutaneous leiomyomas, another dermatologic syndrome, premature uterine leiomyomas that are very, very aggressive, typically resulting in hysterectomies before the age of 30. And then type 2 papillary renal cancer, which is a highly aggressive subtype. So here's an 18-year-old female from such a family. She passed away about 6 months after this scan. A 10-year-old female with this complex cystic solid lesion. It's a papillary type 2. She has the FH mutation. She didn't live more than a year from that scan. So we began to get very alarmed about this and trying to seek these patients out way earlier than they were presenting. So began a screening protocol. So this is a 24-year-old from a family, and there was a cystic lesion. I think you might perceive a little nodule, easier to see on the MRI. And then a year later, there are 2 little nodules. It's a little bit bigger. I mean, it's a cystic lesion with a little nodule. She's from a family like this, so we operate. And it turns out this lesion is a type 2 papillary lesion, but this lesion has already spread into the parenchyma. This is a section from normal appearing renal parenchyma immediately adjacent to that lesion. So this is a truly highly invasive tumor. And what you see on radiology underestimates the extent of disease significantly. Another example, cystic solid lesion in the right side. This is a 60-year-old patient. MRI, which we prefer to do now, shows a nodule. Again, invasive into renal parenchyma, even at this very, very small size. And now, I'm going to show you some incredible lesions on MRI, very much at the limits of what we can detect. Papillary type 2, this lesion in particular was not only papillary type 2, but already invasive into renal parenchyma. So this is a serious gene, not to be messed with. What causes it? Fumarate hydratase mutation. Well, that may jog some distant memories from medical school of the Krebs cycle, maybe some nightmares from med school about the Krebs cycle. But fumarate hydratase is one of these enzymes that converts fumarate to malate. And you think, how can a cell survive with a mutation in this? Well, remember, it's only one copy that's initially deleted. But in fact, the cell can survive without fumarate hydratase, but it doesn't like it at all, and it starts to drive adverse pathways that lead to very aggressive tumors. And they're very metabolic. Unlike conventional renal cell carcinoma, these are readily detected on FDG. Here's some metastases on FDG. And this is a lesion that very much surprised me. It was a patient with renal cancer that was from HLRCC, very vague defect in the liver, PET scan, clearly active. This was metastatic disease to the liver. And a related disorder that we've more recently discovered is succinate dehydrogenase cancer. And this is a syndrome that involves PHOs, paragangliomas, and renal cell carcinoma. And the next enzyme back in the Krebs cycle is this subunit B of succinate dehydrogenase mutation, and that converts succinate to fumarate. You take out this gene, and you also get very aggressive renal cancers. So this is an example of one of these SDH renal cell carcinomas. It's an oncocytic type renal cell carcinoma, which again is one of these hybrid type designations. There's actually a spectrum of these kinds of diseases. So this has been a little bit of a whirlwind through what we've learned by studying families with renal cancers. And what we can summarize from this is a genescape of human renal epithelial neoplasms. So clear cell carcinoma in its purest form is clearly related to von Hippel-Lindau disease. The MET gene is related to type 1 papillary disease, which is generally quite benign. Fumarate hydratase mutations, however, result in this very aggressive papillary type 2 lesion. Sort of in the intermediate area is the folliculin Birt-Hogg-Dubé syndrome with chromophobe and oncocytomas, as well as clear cells. Other speakers will talk about tuberous sclerosis. TFE3 is a new syndrome that I didn't have really time to talk about. It also has a very aggressive phenotype, mainly clear cell. Oncocytic and clear cell chromophobes have genes associated with them. We're working on new genes every day. The number of patients who fall into unclassified familial renal cancers is diminishing every day. And what this means is that we are working on a database that will enable, in the future, I think, a model for many diseases throughout the body, where knowing the gene that a patient harbors in their germline, not in their tumor necessarily, but in their germline, will inform what we should look for on an image. And I think it's a great model for the future. Now, one of the interesting insights into this kind of work is that Most of these genes that are involved are also very critical to metabolic pathways in the cell. And we know, of course, that cancers engage more energy than normal cells, but it's kind of striking that all of these kinds of genes are clustered around very common pathways that are involved with HIF1 alpha and metabolic control of the cell. So it gives insight into the future therapies where we will try to attack the metabolic basis of kidney cancer. And you know, this tumor cancer genome atlas is expanding every day, and more and more of these different genes are being identified, and I think it's definitely in our future that this will be a part of what we do. So with that, I'll conclude, and we'll seek any questions that you might have, and thank you for your attention. Does anybody have any questions? I have to check our virtual people here. They're very thin. Oh, Dr. Choiki. Any data on phosphorus MRI spectroscopy and HLRCC to detect the double hit state? Not that I'm aware of. Sorry. Okay. Well, with that, I'd like to, any other questions? With that, I'd like to move on to our second speaker, Dr. Petra Vaitai, who will be discussing, are you going to be discussing?
The phacomatoses.
Phacomatoses.
Yeah, the phacomatoses, neurocutaneous syndromes. Should I press the time?
Okay.
Okay. Good morning. The phacomatoses, or neurocutaneous syndromes, are disorders of the CNS that additionally result to various degrees in lesions of the skin. All of the phacomatoses are rare diseases. We will both review the CNS and extra CNS imaging characteristics of each disorder, as well as some imaging follow-up guidelines and take-home points. In the interest of time, we unfortunately cannot cover the complex clinical presentation, staging, grading, prognosis, and treatment of each disorder in detail. And because von Hippel-Lindau disease was addressed by Dr. Choiki, I chose to omit the entity in the interest of time. So neurofibromatosis type 1, also called von Recklinghausen's disease, after the 19th century German pathologist who first documented the disorder, is the most common of the disorders we will discuss today, with an incidence of between 1 in 2,600 and 1 in 3,000. NF1 has specific CNS and non-CNS manifestations. The CNS findings include white matter lesions, optic nerve gliomas, optic pathway gliomas, and other gliomas. Non-CNS findings include neurofibromas, plexiform neurofibromas, dysplastic skeletal lesions, vascular dysplasias, and cutaneous manifestations. Foci of myelin vacuolization are essentially areas of increased T2 intensity composed of dysplastic neurons and microcysts. On MRI, these lesions generally show no mass effect, unlike astrocytomas, the main differential in NF1. They do not enhance, but they do show restriction on diffusion imaging. These lesions increase in number in the first decade, after which they usually regress. Our image demonstrates foci of increased signal in the temporal lobes and in the basal ganglia, consistent with myelin vacuolization on these images. Optic nerve gliomas are fusiform optic nerve masses with variable posterior pathway involvement. About 50% of them extend to the chiasm, hypothalamus, and retrochiasmal optic pathway, but optic radiation involvement is very rare. There's an 11 to 30% incidence in patients with NF1, and most are pathologically consistent with pilocytic astrocytomas. Less than 20% of optic gliomas in the setting of NF1 are frankly malignant, and they have a more indolent clinical course than sporadic cases. In addition to optic gliomas, patients with NF1 are at an increased risk for developing other CNS neoplasms, particularly astrocytomas and brainstem gliomas. Several small series have suggested that NF1 patients who have optic gliomas are also more likely to develop secondary primary CNS neoplasms, such as medulloblastoma and ependymoma. These figures demonstrate enhancing frontal lobe, and corpus callosum splenial gliomas. Neurofibromas are benign peripheral nerve sheath tumors that are comprised of a mixture of Schwann cells, fibroblasts, and mast cells. Although there are several types, such as cutaneous and subcutaneous, it is the presence of the plexiform neurofibroma that is strongly suggestive of NF1. They consist of sheets of collagen and Schwann cells that spread in an aggressive manner and tend to involve the scalp, neck, mediastinum, retroperitoneum, cranial nerve 5, and the orbit most commonly. My images show post-contrast MRI sequences demonstrating a plexiform neurofibroma of the left neck, and then plexiform neurofibromas along the course of the sciatic nerves, and one encasing the ankle. Of the different types of neurofibromas that I covered, the plexiform neurofibromas can undergo malignant transformation. The lifetime risk is between 5 and 13%. It's concerning to find rapid growth of a nodule within an existing plexiform neurofibroma on serial imaging. Here I'm showing an axial contrast-enhanced CT scan with an enlarging nodule in the right abdominal wall and an upper thigh enhancing nodule on MRI in the same patient that were pathologically consistent with sarcomatous degeneration. Some of the many bone abnormalities that can be seen in NF1 include long bone dysplasias that present in young children as anterolateral bowing of the tibia and fibula, which can lead to pathologic fracture and pseudoarthrosis at the fracture site, as you can see on this image. Posterior vertebral body scalloping that is a sequela of spinal dural ectasia. Defective ossification of the sphenoid bone that is seen 50% of the time in NF1 can result in facial asymmetry. The left globe here is small and calcified due to neurofibromatosis of the left orbit. And ribbon ribs are also a classic finding of NF1. Hypertension is a frequent finding in adults with NF1 and can develop during childhood. Vascular lesions producing renovascular hypertension are more common in NF1 than in the general population. Histologically, these vessels are surrounded by neurofibromatous tissue, and in the adventitia, which results in fragmentation of elastic tissue, resulting in stenosis and poststenotic dilatation, as seen on this reconstructed CT image above from our institution involving the right kidney. They had also had a pelvic left kidney. The vascular dysplasias can involve the vessels within the kidney as well as the main renal arteries. So the approach to treatment really depends on the type of tumor, its effect on adjacent tissues, and related complications. Clinical evaluation appears to be more useful to detect complications than screening investigations in asymptomatic patients, and screening is not incorporated into NF1 guidelines given the long period of risk. So moving on to neurofibromatosis type 2, it's more rare with an incidence of 1 in 25,000 to 1 in 30,000. It is a disease of multiple intracranial and spinal schwannomas, meningiomas, and ependymomas. Patients typically present around 20 years of age with the following neurological lesions: bilateral vestibular schwannomas, schwannomas of other cranial nerves, intracranial meningiomas, spinal tumors, both intra and extramedullary, and peripheral neuropathy. Almost all vestibular schwannomas in NF2 are benign. The problem is due to their bilaterality and location, and when left untreated, they can extend medially and cause brainstem compression and hydrocephalus. These patients almost all eventually become completely deaf. Our image demonstrates bilateral enhancing masses of the CPA-IAC cisterns, and these can also flare the internal auditory canal when large. Other cranial nerves are also often involved. The trigeminal nerve, more often than the oculomotor or spinal accessory nerve. Our image here demonstrates an IAC schwannoma on the left, and then a trigeminal schwannoma in Meckel's cave on the right. Approximately 1/2 of patients have meningiomas, and multiple meningiomas are often present. The meningiomas seen in NF2 patients are more frequently atypical and anaplastic compared to the sporadic tumors. They are mostly intracranial, although intradural and extramedullary spinal meningiomas are also seen. In our figure on this sagittal post-contrast image, there is an aggressive calvarial intraosseous meningioma with expansion of the diploic space. And on the right image, there's a dural-based right temporal enhancing meningioma. Approximately 75% of intramedullary spinal tumors are grade 1 or 2 ependymomas. They are mostly heterogeneous, enhancing, often partially cystic intramedullary masses. They expand the cord and can be associated with syrinx, as in this central image, where you see the enhancing mass and this syrinx with some cystic spaces. And then the image on the left has an intramedullary enhancing mass with no associated syrinx. And then our third image is demonstrating an extramedullary thoracic spinal canal tumor. So when a patient has an NF2 mutation, cranial spinal MRI is performed beginning at the age of 10 to 12 years, and it's repeated every 2 years for those who are less than 20 years old, every 3 to 5 years when the patient is over age 20. If tumors are detected, they are imaged annually for complications or to assess progression. Tuberous sclerosis complex is a disorder of multi-organ hamartomas and most commonly occurs spontaneously in about 60% of the cases, but it's also seen in an autosomal dominant form. It arises in 1 in 6,000 to 1 in 15,000 live births. The characteristic findings are facial angiofibromas, mental retardation, and seizures are the clinical triad. All three are present in approximately 1/3 of the cases. Tuberous sclerosis can involve all parts of the body, and the expression of the disease varies substantially. Some of the CNS imaging findings include periventricular and subependymal nodules, cortical and subcortical tubers, subependymal giant cell astrocytoma, white matter radial lesions. Non-CNS findings most commonly are renal angiomyolipomas and cysts, and cardiac rhabdomyomas, which tend to regress in childhood. The lungs are involved by cystic lymphangioliomyomatosis or fibrosis, and there are many solid organ adenomas and leiomyomas. So on this first slide, most subependymal nodules are calcified in adults, whereas only 50% of the parenchymal hamartomas are calcified. This CT image is demonstrating calcified subependymal nodules and some calcified parenchymal hamartomas. And this is an axial T2-weighted MRI image showing the subependymal nodules. And in infants, they should not be confused with subependymal nodular heterotopia, as they are not isointense to gray matter. It should be noted that the number, size, and location of tubers is not directly related to the severity of neurological symptoms in adults. These tubers are bright on long TR sequences and well seen on FLAIR sequences, as these top two images demonstrate. They expand the gyri and give it a clubbed appearance. And in infants who are not myelinated, where there's decreased T2 cortical signal, the tubers are dark. Subependymal giant cell astrocytomas generally occur around the foramen of Monro. As opposed to subependymal nodules, these lesions enhance commonly and uniformly. They're larger, they grow with time, and can cause hydrocephalus, and they have a lower rate of calcification. Nonetheless, it's believed that these lesions arise from subependymal nodules, and they occur in 6 to 16% of patients with tuberous sclerosis and have a small malignant potential. So one is demonstrated on the left here, and a much larger lesion on the right. White matter lesions may appear on MRI as either curvilinear or straight thin bands radiating from the ventricles. That's what they look like most of the time, about 90%. They can also be wedge-shaped lesions with the apices at the ventricles or tumefactive foci of abnormal intensity. Besides cardiac rhabdomyomas, AMLs are the most common non-CNS manifestation associated with tuberous sclerosis. And these are classically benign renal tumors composed of abnormal blood vessels, smooth muscle, and fat. There's a broad range of prevalence that generally increases with age. They are monitored for growth to be embolized when reaching approximately 4 centimeters to prevent hemorrhage. So the top image shows characteristic macroscopic fat within bilateral large angiomyolipomas. And this is an ultrasound image demonstrating an echogenic mass in the kidney in a child with tuberous sclerosis. Tuberous sclerosis results also in disorderly smooth muscle growth in the lungs, affecting the bronchioles, alveolar septa, and lymphatics. And while sporadic and almost exclusively seen in women of childbearing age, LAM can be seen in tuberous sclerosis in females and males, although the symptoms are more prevalent and severe in female patients. So the findings are numerous thin-walled cysts that vary between 2 millimeters and 2 centimeters in size. There can be just a few scattered cysts or complete replacement of the lung. So in tuberous sclerosis, surveillance brain MRI is performed every 1 to 3 years during childhood and adolescence, and angiomyolipomas are screened with ultrasound in children from either 1 to 3 years, 3 years if there are no prior lesions seen on imaging. And isolated tubers can be resected if they are identified as a seizure focus among many tubers. And the indication for surgical resection of subependymal giant cell astrocytomas vary, but they include the presence of hydrocephalus or increased intracranial pressure, interval increase in tumor size, or new focal neurological deficits attributable to the tumor. So finally, I'm going to discuss Sturge-Weber syndrome or encephalotrigeminal angiomatosis. This is a rare disease with an incidence of 1 in 50,000, and it occurs sporadically with equal male and female incidence. So the clinical profile includes the classic nevus flammeus or port wine stain, seizures, strokes, and hemiparesis, cognitive deficits and behavioral problems, glaucoma and other ophthalmologic findings, and growth deficits. The characteristic port wine stain or capillary malformation is usually primarily in the distribution of V1, so appearing on the forehead and the eyelid. In this patient, V1 and V2 were involved. The CNS manifestations of Sturge-Weber syndrome are due to chronic venous ischemia from progressive venous occlusion of the leptomeningeal capillary venous malformations that are characteristic of the disease. This figure is a post-contrast coronal image of a 10-month-old female with Sturge-Weber syndrome, and it demonstrates serpentine enhancement of thickened pia, demonstrating the degree of vascular abnormality. You can also see that there's cortical atrophy of the involved frontal and parietal lobes with associated volume loss. Bilateral involvement is seen in approximately 1/5 of patients. In the same patient, we also see another typical finding, which is enlargement and enhancement of the choroid plexus. It's ipsilateral to the port wine stain. In this case, it's bilateral. The size of the choroid plexus and the extent of leptomeningeal involvement in children with Sturge-Weber syndrome correlates well. This is the same patient demonstrating a CT findings of Sturge-Weber syndrome, including cortical calcification or the tram track sign here posteriorly. This is underlying the leptomeningeal vascular malformation, and there's associated hemiatrophy of this cerebral hemisphere. So pial angiomatosis may be occult if there is no facial lesion to prompt imaging, and a negative brain MRI at 1 year of age has been shown to exclude a leptomeningeal lesion, and only a small proportion, about 8% of children in the general population who have a port wine stain have Sturge-Weber syndrome. So in summary, I've covered some of the very specific imaging findings that can help diagnosis of each of their neurocutaneous syndromes. With NF1, it's the optic nerve or pathway gliomas and plexiform neurofibromas. With NF2, it's the bilateral vestibular schwannomas. With tuberous sclerosis complex, it's the subcortical tubers, subependymal nodules, and multi-organ hamartomas. And with Sturge-Weber syndrome, the leptomeningeal capillary venous malformation. These are all rare diseases with very specific imaging characteristics to guide diagnosis. They are highly variable in expression, but all with significant morbidity. And screening and imaging aim at early detection and symptomatic treatment of complications as they occur. Thank you.
Are there any questions? I had one.
Yeah.
Let's see. So I was intrigued by the concept that the cognition problems in TSC are not related to the lesions. So is it understood what it is related to? And what's the natural course?
I've read, it's been shown that sometimes the children who have more of those lesions do have more severe symptoms later, but it's not always the case. So they don't really know, the link is not really known. And they just tend to, involute over time. I'm not sure what the exact reason is.
Okay.
I never could find a good reason for that.
It's really interesting. Yeah. I'm trying to get our...
You can elucidate that.
Just the brain disorder.
Yeah.
That's an underlying anatomic structural problem.
Yeah, there's some underlying anatomic disorganization that we can't see in the imaging catalog. That's what it says.
Yeah, there was never any really specific reason that I found.
Okay, so I just want to apologize to our virtual audience that I'm having a little trouble. If you're trying to ask a question, I'm having trouble opening your questions right now. I'm not ignoring you. Well, sort of.
Okay, thank you.
Okay, so our next speaker is Dr. Richard Doe, who's going to discuss Lynch and other colonic hereditary cancers.
Thank you, Peter.
Oh, great. Okay.
Good morning, everybody. I'm going to talk about some of the advances in genetics for Lynch and other hereditary colonic cancer syndromes. I'll illustrate both GI and extraintestinal malignancies in these syndromes, and we'll examine the role for imaging and screening and monitoring these patients. So, colon cancer is, as you all know, quite common, with over 1 million cases diagnosed every year worldwide. It's the second most common cancer in women and the third most common cancer in men. And the sad truth is the majority still die of metastatic disease. So one of the goals, public health goals, is to identify patients who are at high risk for colon cancer so that we can intervene and resect these tumors before they metastasize. Now, just a show of hand, how many has seen a colon cancer on imaging this past year? I see a few handfuls, maybe about 20. If about 20 of you have seen colon cancer, maybe one of those 20, by statistics, would have had Lynch syndrome. So it turns out that while the vast majority of colon cancers are still sporadic, about 70 to 75% of them, a significant number of them are familial. And about 3 to 6% of them have a highly penetrant germline mutation, Lynch syndrome being the most common, around 2 to 5%. About 20 to 25% are so-called non-syndromic familial presentation. That is, they have 2 first-degree relatives with colon cancer as well, but we don't quite understand why it has a familial component. We suspect a familial component or hereditary component when there's an early age of diagnosis, when multiple polyps are seen on colonoscopy, when there's a synchronous cancer diagnosis or a strong family history. So we'll talk about the most common one, Lynch syndrome, which was previously called HNPCC, or hereditary non-polyposis colon cancer, and you'll understand in a few slides why that term has fallen out of favor. So it was first described by Henry Lynch, who described this syndrome in 1966, and numerous criteria have emerged, including the Amsterdam criteria in 1990, which was revised in 1999, followed by the Bethesda guidelines, and none of these guidelines are perfect, and they're still being debated. It is autosomal dominant with a frequency of about 1 in 500 to 1 in 1,000. And in terms of genetics, it involves a mutation in the vast majority of patients in one of these mismatch repair genes. So most commonly MLH1, MSH2, less commonly MSH6 and PMS2. So what do these genetic alterations result in? So these code for different proteins that heterodimerizes and lead to DNA repair, as you can tell from the name. When you lose the ability to dimerize, this protein, the expression is lost, which can be detected by immunohistochemistry, as you can see on these pathologic slides. So this is a normal patient with normal expression of MLH1 and MSH2, and you can see in an affected patient with reduced protein expression. So immunohistochemistry is one way to screen for these patients. Loss of this protein can also lead to accumulation of DNA errors, which then leads to microsatellite instability. And so this is the second test you can use, PCR, to look for microsatellite instability, which is more expensive, so less commonly used than immunohistochemistry as a first-line test. So colon cancer occurs quite frequently in these patients. The risk is about 60 to 80% compared to 5% for the general population. These patients tend to present earlier, around 45 compared to 65 for the general population. They are more commonly right-sided, more commonly mucinous. They can be synchronous and metachronous, and they can present at a low pathologic stage with a better prognosis overall than sporadic cases. Now, Lynch syndrome patients obviously develop extracolonic tumors. The traditional Lynch syndrome was described as colon cancer, endometrial, and ovarian cancers. And the risk of ovarian cancer in women is about 40 to 60% by age of 70, and they can actually present first equally as frequently as colon cancers. They can also develop cancers in the stomach, small bowel, biliary tree, etc. And the exact frequency of these cancers is quite variable, and they're dependent on geography and on the genes involved. So it depends on which of the 4 genes you have affected, depends on where you live. So in China, for example, the second most common cancer after colon is actually gastric cancer. This is a woman in her 40s whose mother had died of colon cancer at the age of 48, and this patient developed endometrial cancer at the age of 45, and a couple of years later developed colon cancer as well. This is another woman who on sagittal T2 and sagittal diffusion weighted images, you can see a large mass which has shown no myometrial invasion, and this was an early stage endometrial cancer in a relatively young woman. Now, some of these Lynch syndrome patients are named or have variants which are actually named, one of which is Muratori, which are patients with visceral carcinomas, sebaceous gland neoplasms, and cutaneous keratoacanthoma. This is a patient who, in 1987, at the age of 57, developed endometrial cancer, which was resected, and I don't have imaging for that. But 14 years later, developed a transitional cell carcinoma of the left renal pelvis, you can see on IVP. 6 years later, developed pancreas cancer in the setting of IPMN. And then 4 years later, or nearly 30 years after the first presentation of endometrial cancer, developed a sigmoid cancer, as you can see here on the CT images. They actually had a synchronous cancer elsewhere in their transverse colon as well. And this was at the age of nearly 88. Turcotte syndrome consists of patients who have both a brain tumor and either Lynch syndrome or familial adenomatous polyposis. The brain tumors are usually glioblastoma in the setting of Lynch. This patient turns out to have a low-grade astrocytoma in the left frontal lobe at the age of 29, and then a year later developed a locally invasive rectal cancer. You can see here on sagittal T2. This is another patient with Lynch syndrome, left-sided colon cancer, FDG avid, and you can see a large mass in the right upper quadrant, invading the liver with retroperitoneal adenopathy, and this was adrenocortical carcinoma, metastatic, and unfortunately this patient died soon thereafter. So we know these patients develop colon cancer, we know these patients develop multiple cancers in other organs. What can we do to help them? So colonoscopy is offered every 1 to 2 years, starting at the age of 20 to 25, and it's the one screening mechanism that actually has been shown to improve survival in this syndrome and among all the other syndromes. All the other screening recommendations are just recommendations. This is the one that has been shown to improve survival. Risk-reducing colectomy is offered as a therapeutic option. For endometrial and ovarian cancer, endometrial biopsy, starting at an early age, combined with transvaginal ultrasound and CA-125 testing, is the screening recommendation. Hysterectomy and bilateral sublingual oophorectomy can reduce your risk of both cancers. Whether or not it improves your survival is not clear at this time. For upper GI tract cancers, endoscopy is offered. And for urinary tract cancers, they're relatively rare in this population, and so perhaps patients, those with the highest risk, for example, MSH2 mutations and male, may benefit from these screening strategies, such as urinalysis with cytology and renal ultrasound. If you're curious about the role of CT colonography, at this time, it's not recommended. The ACR came out with an appropriateness criteria, 2010, saying that CT colonography and barium enema are usually not appropriate for colon cancer in high-risk patients, including HNPCC, i.e. Lynch. So moving on to familial polyposis syndrome. So these are patients who have a family or personal history of colon cancer, as well as multiple polyps, and it's useful to divide them into two categories, those with adenomatous polyps and those with hamartomatous polyps. And just to refresh your memory, hamartomas are non-neoplastic tumors comprised of disorganized normal tissue. So you can see on this endoscopic image of the stomach innumerable small polyps carpeting the gastric mucosa. So these are patients who have numerous or over 100 adenomatous colorectal and GI tract polyps. It's much more rare than Lynch syndrome, occurring in about 1 in 6 to 13,000 patients. But unfortunately, they carry 100% lifetime risk of colon cancer. The cancers can also occur throughout the GI tract, which makes sense since they have polyps everywhere. In the duodenum, about 4 to 12%. They also develop pancreas cancer as well as thyroid cancers in the low 1 to 2% range. These patients have germline mutations in the adenomatous polyposis coli, or APC, tumor suppressor gene, which is involved in a Wnt signaling pathway, and over 800 mutations that have been identified, mostly truncations. Some of these mutations are less penetrant, or rather less severe in manifestations, and they're so-called attenuated versions of FAP, defined by less than 100 adenomas and later age onset of colon cancer. There are two main variants, Turcotte syndrome, which I also talked about earlier. It's also called Krell syndrome, specifically in FAP patients, and Gardner syndrome, which I'll talk in a few slides. So, as you can imagine, these patients have 100% lifetime risk of colon cancer. They're very aggressively screened. Usually colonoscopy is recommended at the age, starting at the early age of 10 to 12, starting at, for every 1 to 2 years. The average age of colon cancer diagnosis is 39, but 7% of them develop as early as the age of 21. And so prophylactic colectomy is often offered as a therapeutic option. For the risk of stomach and small bowel cancer, endoscopy is recommended every 1 to 4 years. And for thyroid, amazingly, annual physical exam is still the recommendation, and ultrasound has not been shown to have a role in this patient population. Now, desmoid tumors are very interesting. Desmoid tumors, illustrated here on this coronal CT image, is an infiltrative mass surrounding the SMA and its branches, can occur and typically occurs after colectomy. So the patients have a colectomy as a risk-reducing strategy, and several years later develop a desmoid tumor. If they have a family history, it's recommended to screen for these about 1 to 3 years after the colectomy, and then 5 to 10 years after that, or earlier, obviously, if they're symptomatic. And given the long interval at which we need to follow these patients and the early age at which they may get these colectomies, MRI may be a better strategy to survey them. And our institution, once they're diagnosed with a desmoid tumor of the abdomen, they're followed with MRI. For pancreas, even though they have a slightly increased risk of cancer, there's no screening recommendations. Oh, and just to be explicit, the NCCN is really a national comprehensive cancer network in the United States. And I know there's some international colleagues here. You may have different recommendations in your own countries. So desmoid tumors can get quite large, as in this patient, but they can respond to therapy. So there's a lot of therapies being investigated right now. They occur in about 10% of patients with FAP. They can cause significant morbidity and mortality. They're mostly intra-abdominal, but it can occasionally occur in extra-abdominal sites, and including the extremities. While they have no metastatic potential, as you can imagine from this tumor, they can be locally infiltrative and can cause bowel obstruction when they get quite large. The therapeutic options that have been tried are all over the place. We're talking about anti-inflammatories, hormonal therapy, tyrosine kinase inhibitor, cytotoxic chemotherapies, radiation surgery. And fortunately, there are some more concerted efforts to identify what is the most effective treatment, and there are ongoing clinical trials, such as with sorafenib, to identify what clinicians should do first when we encounter desmoid tumors. Gardner syndrome is an FAP variant. It's described in 1951 by Alton Gardner, and occurs in about 1 in 14,000 patients. So obviously they have GI tract polyposis, but also develop multiple osteomas, And mesenchymal tumors of the skin and soft tissues, such as desmoid tumors, as I already talked about, and epidermoid cysts, such as illustrated here on the sagittal T1 and T2 inversion recovery sequence, as a well-circumscribed lesion. Dental anomalies occur in about 30%, such as supernumerary teeth. Finally, I'm going to talk about hamartomatous polyposis syndrome. There are many of them, but only the first two really have a significant risk of colon cancer. We talk about Peutz-Jeghers, which is the most common one, with about a 50% risk of colon cancer. Juvenile polyposis syndrome, about 40 to 50%. And then we have the following, which are Cowden, Bananian, Riley, Ruvalcaba syndrome, Cronkite-Canada, and Gorlin syndrome. So they're characterized by hamartomatous polyps throughout the GI tract, as well as extraintestinal malignancies, just like our other syndromes. Peutz-Jeghers is quite rare, but is the most common form of hamartomatous polyposis, occurring about 1 in 29,000 to 120,000. They have characteristic mucocutaneous pigmentation or skin melanosis, which is usually perioral on the lips, hands, and feet. It is also autosomal dominant with mutations in the serine kinase gene on chromosome 19. And these patients develop quite large polyps, as you can see on this endoscopic image of the small bowel. These polyps develop in the second or third decade in about 80 to 100% of patients, and because of their large size, they can act as lead points. And so these patients can present first with interception or symptoms of bowel obstruction, and it can also present first with GI bleeding. The colon cancer risk is about 50%, and they also develop additional cancers of the pancreas and the stomach. In women, there's quite a high risk of breast cancer and gynecologic tumors. This is an example of a 37-year-old male with hamartomatous polyps in the small bowel and colon. You can see here these polyps are quite visible on CT enterography. There's multiple coronal images. You can see nice distension of small bowel, and these rather large polyps, and they tend to be about 1 to 3 centimeters. They tend to be clustered rather than carpeting the entire tract, and they tend to spare the esophagus. And we find them most commonly in the jejunum and the ileum. These polyps consist of smooth muscle cores, and they're covered by mature glandular epithelium. This is another woman, a 55-year-old woman who had perioral pigmentation, which is classic, a previous total colectomy for polyps, and new watery vaginal discharge. You can see multiple polyps remaining in the small bowel. And I don't know how well this projects, but on sagittal and axial T2 images, you can see this clustering of high T2 signal, cystic appearing lesions. And you may have guessed at this time, this is adenoma malignum, which is a relatively rare cancer of the cervix, but not so rare in Peutz-Jeghers patients, and it has, unfortunately, a very aggressive behavior. Because of their increased risk, different guidelines have been offered. Colonoscopy every 2 to 3 years, starting in the late teens. For breast, mammography and MRI, starting annually at the age of 25. MRCP and endoscopic ultrasound every 1 to 2 years, starting at the age of 25 as well. And their risk of pancreas cancer is about 100 times that of the general population, with a lifetime risk between 11 and 36%. Gynecologic tumors, transvaginal ultrasound, starting at the age of 18 to 20. And for CT, for the small bowel, CT enterography, starting at the age of 8 to 10. And CT enterography is quite involved. There's a lot of radiation, and perhaps there's a role for MR enterography, which is being investigated for this patient population. But as you can imagine, given the rarity of this disease, proving that any one of these screening mechanism actually works will probably be very hard to do, but they're still recommended. Very briefly, juvenile polyposis syndrome, 1 in 100,000, with mutations in one of these genes, MAT4, MATH4, and BMPR1A. And they're involved in the TGF-beta-related pathways. They have a nearly identical risk of colon cancer from Peutz-Jeghers, and colonoscopy is offered around the same age group. They also have a high risk of stomach cancer, and there's actually different forms of juvenile polyposis, which I won't go into today. Cowden syndrome is now part of the P10 or phosphatase and tensine homolog gene syndrome. It occurs in 1 in 200,000, autosomal dominant, and the gene product acts as an off-switch in the PI3 kinase pathway. The problems are quite different from Peutz-Jeghers. They're very much smaller, they're sessile, they're less cyclophytic, and they commonly occur in the esophagus, stomach, and colon. And this one was actually in the rectosigmoid junction. They have very pathognomonic skin characteristics, with the vast majority develop microcephaly, which is detected on physical exam, and screening is offered for cancers of the breast, if you're a woman, for the endometrium and the thyroid, the risk of cancer is just slightly increased compared to the general population, about 10%. So in summary, Lynch syndrome, you probably have a mutation in one of your mismatch repair genes, which can be detected by immunohistochemistry or a PCR test looking for microsatellite instability. There's about a 60 to 80% risk of colon cancer. And we're increasingly understanding that which gene mutation leads to which phenotype, but that's an area of active investigation. There are survival benefits for prevention of colon cancer with optical colonoscopy. There are screening guidelines, which are not really evidence-based, but are still guidelines offered for other cancers. And at this time, there's no role for screening with CT colonography. Familial adenomatous polyposis syndrome, or FAP, are mutations in the APC tumor suppressor gene and carries a 100% risk of colon cancer. They're screened very aggressively, very early on, and colectomies are offered early with a subsequent risk of developing desmoid tumors. And hamartomatous polyposis syndrome are quite rare, the most common being Pearce-Jaeger, and these patients develop quite large polyps that can lead to a risk of intussusception and bowel obstruction. And these patients have about a 50% risk of colon cancer. And obviously, both of these syndromes and Lynch syndrome have a high risk of other cancers, and multiple guidelines are now available for screening. Thank you very much.
Great. Are there any questions, Jim?
Is Lermite flow still considered to be related to Calvin syndrome?
No, I'm not sure. I'll have to look that up.
Can I ask you a question about, I was interested about the trigger for prophylactic colectomy in FAP, and also I didn't notice it in Lynch.
It is offered in Lynch syndrome.
So can you describe sort of the decision points that will result in that?
Well, I'm not a surgical oncologist, but I presume that once you identify a patient, so unfortunately a lot of these patients are identified after they have colon cancer, because unless they have a strong family history, we're not going to identify which patient should be screened at the age of 10. But if you do develop colon cancer, that's when colectomies are offered, because they have a risk of synchronous and metachronous cancer. It's not uncommon to find synchronous cancer when you first detect the incident case.
Okay. So we actually have a few questions from our virtual audience. Why are gastric cancers more common in China in Lynch syndrome? Is it environmental?
That's actually, that's just an observation. We don't know why it occurs in China, but presumably it's a combination of geography and environmental. These are, I don't know if we were Chinese and moved to America and have Lynch syndrome, what would be the risk? It's not clear.
So is there an increased risk of Lynch syndrome in China? Or is it's just sort of baseline, but it's more associated with gastric in China?
More associated with gastric cancer in China.
So how often are genetic cancer syndromes such as this missed? And what could we do to sort of systematically detect patients with these things?
So it's not, who was aware of Lynch syndrome and all the other cancers before this morning? It's not on our radar as radiologists. It's not on the radars of our community hospitals as much. There's obviously, these patients tend to migrate towards centers of excellence. So given the prevalence of colon cancer and up to 2 to 4% having potentially Lynch syndrome, and then asking a geneticist how common Lynch syndrome is a whole discussion, because there's different criteria now. We probably miss a lot of them. But if you see somebody presenting very early on, 30, 40, with colon cancer, you have to ask yourself, wow, this is unusual. To avoid satisfaction of search and look for other cancers at the same time. So we can play a role as radiologists if we see a young patient with colon cancer. But yeah, we probably miss a lot of these. Yeah. At Sloan Kettering, we have a very aggressive strategy for looking for Lynch syndrome-related mutations when we have a patient who's under the age of 50.
By the way, your enterography images were really good.
Thank you.
I know you probably selected the best ones, but are there any tricks or tips you'd like to share with us?
Oh, you probably have to track down Mark Golub, our CT director, for tips and tricks. We use glucagon just like everybody else, and volumen.
All right. Great. Thank you very much. So we'll move on to our last speaker, Dr. Jim Sperniatopoulos, who will be discussing the MEN syndromes.
Hi, everybody. How are you all doing? I've got nothing to disclose, and I'm going to not disclose it again. So I was given the task of talking about multiple endocrine neoplasia syndromes, and I really appreciate having the opportunity to talk to you about it. I feel like I'm out of my element because I'm a neuroradiologist, and most of these things are going to be below my region of interest. So I got very anxious getting ready for the talk, so I hope that you'll all be very kind as I go along. I'm going to have a handout for this lecture, a very extensive one, posted by the end of the week, and you can find it on our MedPix website. I've got nothing to disclose. I've been through airport security so many times. They've seen everything. They recognize me, just to let you know. I work for the government, and I'm here to help. I work for the Uniformed Services University of the Health Sciences, which is right behind the Naval Hospital. It's the military medical school for the United States, so if you don't know, it's like the Naval Academy, Air Force Academy. I think we have the world's best dressed medical students, whether it's summer or winter. And if you've ever been on our campus, they're allowed to wear their camouflage uniforms 4 days a week, so sometimes you have no idea whether anybody is there or not. So I was getting ready for the talk, and I was getting very anxious. I had palpitations, and I was sure that I had a pheo. And then I had hot and cold flushing, and I thought I must have a carcinoid. And then I started to have reflux and heartburn, and I was sure that I had a gastrinoma. Then I had watery diarrhea, and I thought I had a VIPoma. Then I got really hungry, and I thought I had an insulinoma. And you kind of get the idea that as you're reading about these very complex syndromes, it's very easy to kind of get lost, and lots of names and words here to talk about. So I want to kind of give a little brief introduction, and then we'll talk a little bit about the terminology, and then we'll go over the imaging and manifestations primarily of MEN1, 2, and what used to be called MEN3 and is now MEN2B. So these are relatively uncommon disorders. The prevalence is estimated to be about less than 1 in 30,000. All of these are autosomal dominant. They're thought to be caused by a germline mutation. There's no racial or sexual predilection for having the disease, but some of the features expressed in some patients show gender differences. As neuroendocrine disorders, they're related to cells from the neural crest. And there was a term that we used to use 30 years ago with neurocrystopathy. We used to talk about the phacomatoses and these MEN syndromes as being neurocrystopathies. And we've kind of lost that term. But all of the cells that become abnormal in these disorders are actually related to the embryologic neural crest. By the way, if I talk too fast, which I can do, throw small, harmless objects at me, and I promise I will slow down a little bit. So when you look at the diseases that are called multiple endocrine neoplasia syndromes, we've got Carney's, MEN1, 2, and 3, a new one, MEN4, which also occurs in rats, called MENX, McEwen-Albright, NF1, von Hippel-Lindau disease. There's an awful lot of things that we could talk about today. But what you want to remember is that the MEN syndromes that I'm going to discuss are primarily related to forming solid tumors. In MEN1, we get parathyroid adenomas in virtually 100% of the patients. 30 to 76% of the patients are going to have some kind of gastric, pancreato-duodenal neuroectodermal tumors. And these neuroectodermal tumors can have diverse hormonal or non-hormonal presentations. Gastrinomas, insulinomas, VIPomas, glucagon, somatostatin. We can also have in less than half the patients adrenal cortical adenomas, and pituitary adenomas occur in MEN1 patients in 10 to 60% of cases. There's more than 20 types of lesions that can be associated with MEN1, so there's no way that we can talk about it in a short presentation. MEN2, whether it's 2A or 2B, is characterized by medullary thyroid cancer. The penetrance of that is estimated to be over 100% if patients live to be about age 50. These patients also get pheochromocytoma, and as a reminder, pheochromocytoma is the medullary part of the adrenal gland, and medullary thyroid cancer, that's the cancer type associated with the C cells that make calcitonin, and that's also derived from the neural crest. Patients that have MEN2A may get hyperparathyroidism, and 2B is distinguished by having a marfanoid habitus and ganglioneuromatosis. So these are very complex, and I hope to give you some mnemonics to help remember them. So the goals of imaging in these patients is to do surveillance and also to identify patients who are affected. You have a patient with hypercalcemia who has elevated parathormone, you're worried about them having a parathyroid adenoma. You have a patient that has Cushing's disease and you want to determine whether it's due to ACTH secretion by a pituitary corticotroph tumor or whether it's related to autonomous production of cortisol by an adrenal adenoma. Zollinger-Ellison syndrome, we want to visit the gastrin triangle. Just as a question, how many of you have heard of the gastrin triangle? Okay, so that's a very easy way to remember where to look. Carcinoid syndrome can be solitary part of MEN1. Medullary thyroid cancer, all these patients need to be screened to see if they have MEN2. Pheochromocytomas may be sporadic or part of one of these syndromes. But when you identify a syndromic association, you have to screen all the first-degree relatives, and you have to do surveillance of affected individuals to see if they are developing the complications for these diseases. So John Dopman, who was the first endocrine radiologist I ever met, who was at the NIH, he wrote this great editorial, Multiple Endocrine Syndromes, a Nightmare for the Endocrine Radiologist. And this was written about 25 years ago. So if you do this full time, I'm not going to be offering you any new information. If you don't do this full time, I hope I'm going to pass on to you a couple of things to be sensitive to and help improve our diagnostic accuracy. So some of the take-home messages: if you're looking for a pituitary microadenoma, it appears to be true that the three-dimensional gradient echo sequences, SPGR with gadolinium, are actually better than doing the dynamic images of the pituitary. Almost all parathyroid adenomas are going to be found medial to the carotid sheath. So if you're looking at the neck for a parathyroid-producing tumor, you want to make sure you scan all the way down or image all the way down into the mediastinum, but they're almost always going to be medial to the carotid sheath. The gastrinoma triangle, we want to image early in the arterial phase to look for the enhancement in the gastrin-secreting tumors in the duodenal wall of the pancreas. If you're imaging during the portal phase, you might miss those lesions. Cortisol adenomas typically have enough lipid in the cells that they have a low attenuation on CT, so you want to look for that to see whether they have an attenuation that's less than 5 or less than 10 Hounsfield units. And some people also look at the rate of contrast washout. The other thing about a cortisol adenoma is that it will suppress ACTH secretion by the pituitary, and the rest of the adrenal glands will shrink as a result of the loss of the normal ACTH stimulation. So, being Greek, I had to make up a Greek name for this, so I called it leptoadrenal. Lepto means skinny, and if you have one cortical adenoma, the rest of the adrenal tissue is going to shrink. So let's find out 20 years from now whether people use this term, leptoadrenal glands. And if you're looking for a pheochromocytoma, you can do MIBG, CT, MR, etc. But the primary thing to remember is that the extra-adrenal pheos are much more aggressive than the adrenal pheochromocytomas. So let's kind of think about how we're going to organize our thoughts to remember everything, because at the end of the day, we all have smartphones, we all have access to the internet, we can all contact Dr. Google, our favorite consultant, and look all of these things up. So it's important to figure out if there's a way we can remember these things easily to be able to call up and figure out what we're going to look for. So MEN1 is sometimes called the 3 Ps, because the primary presentations are related to pituitary adenomas, parathyroid hyperplasia, and pancreatic tumors. And it's sometimes called Wermer's syndrome. And this is not a picture of Dr. Wermer, but we'll come back to this later on, because all of these diseases are typically named after dead white European men. So if we go on now, we want to remember that we're looking primarily for pituitary, parathyroid, and pancreas tumors, but these patients also have cutaneous lesions, lipomas, adrenal cortical tumors, carcinoid, and they have been reported to be associated with meningioma and ependymoma. So I want to show you the cutaneous lesions that we get in Wermer's syndrome or MEN1. They get angiofibromas. So my first question was, are these angiofibromas the same as what we see in tuberous sclerosis? And the answer is yes, they're 100% the same as what we see in tuberous sclerosis. But if you have MEN1 syndrome, you only have a few of these. And if you have tuberous sclerosis, you have 10, 20, 30, 40, or hundreds of them. But for the dermatologist, and Tom Darling is a dermatologist at USUS who's also at the NIH, he says that histologically they're identical to what you see in tuberous sclerosis. We want to remember that these patients are going to either have parathyroid adenomas or hyperplasia 100% of the time, pancreatic or duodenal tumors, anterior pituitary tumors. We'll talk about how we work those up. And we want to remember that they're going to have a high penetrance of having skin lesions, which we don't look at as radiologists, but it's very important. So the diagnostic criteria for MEN1, The major criteria, you have to have 2 of these 3 required lesions: pituitary adenoma, parathyroid adenoma, or hyperplasia, and some kind of a gastropancreatic or duodenal neuroendocrine tumor. There's also familial MEN when you don't have all 3 features, but you have a first-degree relative and one of the major features. And this is identifying the population to be screened. And I'm sure all of you are familiar with Star Wars, so Yoda used to always say, "Always 2 there are." So you want to remember that for these diagnostic criteria, we have to have 2 from these 3 options. People have suggested that you want to do gene screening if a patient has a gastronoma, multifocal NETs in the gut, parathyroid hyperplasia or adenoma less than 40 years, recurrent parathyroid tumors, or one of the main but less common features. So this is something that we might suggest to the clinicians, that we've seen one of these lesions suggesting the need for gene testing. So the goals for imaging: for the head, we're looking at the pituitary. For the neck, we want to look at the parathyroid. And I want to tell you that the endocrine surgeons are going to explore the neck. So in some ways, it doesn't matter what we say about the parathyroid glands. It's very important what we say outside of the area of the thyroid bed. It's very important that we identify lesions that are outside of where the endocrine surgeons normally explore. And then if we have to look at the abdomen and the chest. So about 2/3 of patients who have MEN1 who have pituitary adenomas are symptomatic. So that means that 1/3 of the MEN patients are going to be asymptomatic. About 2/3 of them are going to have microadenomas. And the majority of these are going to be functional, even though the patients always don't present with endocrine function. The most common kind of tumor is going to be a prolactin-secreting tumor, which is the same as the general population. And I think we all know that women present when they have a prolactin-secreting tumor because they get the amenorrhea-galactorrhea syndrome. Men who have a prolactin-secreting tumor don't care because they're already accustomed to having amenorrhea. So when you're looking at these tumors or looking for the tumors, you want to remember the context for the patient. So just as a reminder, the sagittal anatomy here, the pituitary gland about the size of a dime at the top of the clivus. Patients who have pituitary adenomas with or without the syndromic association are usually adult patients. Macroadenoma is defined as being larger than 10 millimeters. If it's bigger than 10 millimeters, it will cause a balloon-like enlargement of the pituitary fossa. If it is larger than 10, 13, 14 millimeters, it will press on the optic chiasm and cause that classic presentation of a bitemporal hemianopsia. If the tumor is smaller than 10 millimeters and entirely contained within the normal gland, it's going to be called a microadenoma. And microadenomas tend to enhance a little bit differently from the normal pituitary tissue, so the standard dogma is you get a flip-flop, that the adenoma enhances slower and to a lesser extent than does the normal pituitary tissue. And of course, the patients may or may not have endocrine screening tests that reveal they have the abnormality. So the goal for imaging in MEN1 for the pituitary is to rule out a macroadenoma, and if they have a microadenoma that's secreting prolactin, being perfectly honest about it, it doesn't matter where we say it is, because prolactin-secreting tumors are treated biochemically with bromocriptin. If it's an ACTH-secreting tumor, then we have to think about identifying it for the surgeon, and we also want to think about doing inferior petrosal venous sampling. So I want to show you a couple examples of how we use our imaging. We can do dynamic imaging, taking images every few seconds, but we'll see that the tumor here enhances at a slower rate than does the normal gland. And it's important to remember the classic signs for pituitary microadenoma are deviation of the stalk, upward bulging and downward bulging of the pituitary gland. That's what we look for. So I want to show you this case that I got from Nick Petronas over at NIH. And if we look here, we can see something that looks like it's depressing the floor of the cella, and it looks like it's not enhancing as well as the rest of the gland. So is that the pituitary adenoma in this patient? And it might be, except when you look at the 3D GRE images here, we can identify that the lesion, the corticotroph stimulating tumor, is actually on the opposite side. So this one breaks the rule. And the least reliable rule is deviation of the stalk, but seeing this downward bulge here would make everyone very suspicious that the adenoma was in a different location. So one of the take-home messages is that the 3D GRE imaging with very thin slice thickness is going to be better than doing the regular dynamic imaging for these patients. Here is a huge macroadenoma, and again, it enhances less than the normal gland. The normal gland tissue is being displaced forward, and a little bit of the normal neurohypophysis posteriorly behind it. Macroadenomas can be complicated by hemorrhage and necrosis, etc. So we can see here that another complication is invasion into the adjacent structures, the cavernous sinus. This one is growing down into the sphenoid sinus here. So macroadenoma is a very different problem. We're defining the outlines and contours for the surgeon. They can be complicated by internal hemorrhage and apoplexy. You can see methemoglobin here. I want to show you that the chemical therapy for the prolactin-secreting tumors can be very effective. Dopamine will not only stop the secretion of prolactin, but may actually cause a reduction of tumor size. And somewhere between 50 and 60% of patients will have a 20% reduction in tumor size while they're taking one of these dopaminergic things, these tumors like we saw there. This is an interesting case where the patient had a macroadenoma and then had a cardiac arrest, and they had a spontaneous infarction in the tumor there. And here's another patient who had an infarction. So let's talk about the neck for a second. The parathyroid is hyperfunctioning. How do we know that? Because parathormone is elevated and calcium is elevated. It's a very simple ratio. If parathormone is up and calcium is up, then something is wrong with that normal feedback loop. A lot of different imaging can be used. Ultrasound with Doppler can demonstrate vascularity. Most of the time we're doing nuclear medicine imaging, and you just want to remember that the lesions are typically going to be medial to the carotid sheath. So this is an illustration from the literature, and again it identifies multiple areas where parathyroid-producing adenomas were located, and again they're going to be medial. So if we look at the scanning techniques that we can use, we can do dual phase or dual isotope imaging, and I want to show you how that works right now. So if we think about the normal thyroid and parathyroid, the thyroid will pick up protectinate, but sestamibi will be picked up by both the thyroid and by the parathyroid glands. So if you have an adenoma, it might be difficult to identify the contour for a small lesion. But what you do is you take the protectinate image and you subtract that from the sestamibi image, and what you end up with is seeing the adenoma showing up and everything else is subtracted. So how does that work in the real world? If we take a look at this case here, you get the impression that there is a little blip coming off the thyroid, so that could be the parathyroid secreting adenoma. But when you normalize it and then subtract it, you end up very clearly seeing the parathyroid adenoma with this subtracted image. So this is the basic way that we do the subtraction imaging. I wanted to show you one in an unusual location. Here is one that's farther down in the neck. We can see them on ultrasound with increased vascularity. There is a radiologic interventional treatment that has been used for parathyroid adenomas. This is a patient that had an angiogram done, and the patient was given renographin 76, which stained the adenoma because of its increased vascularity, and then basically caused an ablation of the tumor and a reduction of the secretion of the parathormone. Here is a parathyroid adenoma that is actually inside the thyroid gland, and here is one here that's in the area of the carotid sheath. So let me switch now and talk about MEN2A and 2B. And you want to remember that the difference between MEN2A and 2B is that 2A has everything that 2B has, but it also has the marfanoid facies and it has the cutaneous manifestations. And those two features are thought to have 100% penetrance in patients that have MEN2B. So here's our little diagram again. And we want to remember the term medullary. This is the memory hook that I picked up working on this and studying this, is that the lesions that we get in MEN2 are medullary neoplasms of the thyroid and medullary neoplasms of the adrenal gland. So it's a very helpful way to organize your thoughts for these. But in addition, the patients that have MEN2B are going to have neuromas, mucosal neuromas, marfanoid facies, and they may also have ganglioneuromas involving the gastrointestinal tract. Medullary thyroid cancer is so common in these patients that oftentimes they have prophylactic thyroidectomy, which is typically done by the age of 5. So perhaps pediatric radiologists know a little bit more about this than I do. So medullary thyroid cancer has a penetrance that approximates 100%. It's going to be the only feature in something that is part of this family but a little bit different, which is familial medullary thyroid cancer. Patients who have familial medullary thyroid cancer don't have any of the other manifestations. They only have the thyroid cancer. But some people think that they are a version or a variant of the MEN2 syndrome. The medullary thyroid cancer is typically a solid tumor, but not always. It may have calcification. That was an old plain film observation for medullary thyroid cancer. How many of you remember plain radiography? Anybody remember plain radiography? So we'd see calcification in the thyroid gland and think that the patient had one of those calcitonin secreting tumors. Local invasion, liver metastasis, and again, because of the very, very high penetrance of expression of medullary thyroid cancer and the complications for that, typically we recommend thyroidectomy around the age of 5. So medullary thyroid cancer, nothing really specific about a lot of the imaging, a little bit hypervascular, it may become necrotic, it may pick up FDG and be very, very hot. Now I want to talk about pheochromocytoma for a second. It's an adrenal medullary neoplasm. Pheochromocytomas secrete hormones that may be produced by anything along the sympathetic or parasympathetic chain. So we have both adrenal and extra-adrenal secretion of these metanephrines, and that's the problem. So this is a derivative of the neural crest. Catecholamines are secreted, and the vast majority are associated with the germline mutation, the vast majority of the extra-adrenal paraganglion tumors. About half the patients who have MEN2, but not the familial medullary thyroid cancer, are going to have PHEOs. And one of the common themes that you heard from the other speakers is young age of presentation and multiple lesions leads you to thinking about a syndromic association. So that's something that everyone needs to remember when you have a young age of presentation for these things. So you identify that they probably have a PHEO because of the biochemical analysis. You want to look in the adrenal gland to see if it's there. You can do MIBG sensitivity as well. So here is a solid pheochromocytoma. A nice article from the literature, pheochromocytoma, an imaging chameleon. So they don't always look the way they're supposed to, and sometimes they can become heterogeneous and cavitary and partially necrotic, which is what we're seeing here. Here's another very, very large pheochromocytoma, and here's a patient that has lymph node metastasis from a pheochromocytoma. When I was in medical school, for some reason I was fascinated by the names of things, and there's something called the organ of Zuckerkandl, which you've all heard of. It isn't actually one thing. It's all kinds of autonomic nervous system ganglion that are located between and above the SMA and down to the IMA, and also down to the aortic bifurcation. But you can have a PHEO arising in the pelvis, and you can also have one arising from the organ of Zuckerkandl. And again, these are going to be chromaffin cells from the autonomic nervous system, and this one was metastatic to lymph nodes in the abdomen as well as lymph nodes in the chest. And again, the nuclear medicine studies can be very effective in identifying the location of the metastatic diseases, especially fluorodeoxyglucose imaging. And again, multiple lesions here. Major complication of having the extra-adrenal PHEOs is having these lesions. This is a very, very large area of abnormal activity, a huge pheochromocytoma in this 56-year-old woman. Again, we can see it here. There's probably some invasion here of the renal vein, so it's a very significant problem for this patient. Here's a 12-year-old girl. At that age, we'd have to be suspicious. She has one of these germline mutations and a syndromic association. Very hard to see there, easier to see here in the posterior view. And if we look here at our coronal images, we can see the lesion is again partially cavitary and partially necrotic. And this was the specimen showing that cavity there in this patient. So we didn't have a lot of time, and we had a lot of things to discuss, and in some ways talking about the MEN syndromes is kind of like an alphabet soup, because you have all of these different names and all these different acronyms that we have to think about. But I want to try to help you organize your thoughts as you walk out of the room, that you want to remember that MEN1 is the 3 Ps. This is Dean Wormer from Animal House, so from now on the deltas are on double secret probation. But those are the lesions we're looking for in MEN1. We want to remember that medullary neoplasms are what we're looking for as the most common features of MEN2, medullary thyroid cancer, medullary adrenal cancer, which is going to be pheochromocytoma. And you want to remember that the primary difference between MEN2B and MEN2A is the cutaneous findings, and I'll just leave you with this thought. Did Abraham Lincoln actually have MEN2B? Did he have marfanoid facies? Are these lesions on his lips actually mucosal neuromas? The jury is out on all of this, but if you contact Dr. Google, you can learn much more about this. And so SPGR for pituitary microadenomas, parathyroid adenomas are medial to the carotid sheath. We didn't get a chance to talk about the gastronoma triangle. I apologize for that. And MIBG is very good for pheochromocytoma. Thank you all very, very much for your kind attention.